Hello, everyone. My name is Dr. Christine Toki, and it's my absolute pleasure today to present to you a bit on the historical background of the nurse practitioner, the development up to the future. To give you a little history of myself and my role as a nurse practitioner, I have been a gerontology nurse practitioner for about 25 years, so I have a good history of what it was like in the 90s up until now to be a nurse practitioner and some of the changes along the way. I presently, and you'll see on this slide, I'm presently a faculty member at the University of Connecticut School of Nursing. And if you look at the photo on the right, you see a picture of our campus. It's an absolutely gorgeous campus. It's in the northeast corner of Connecticut, about an hour outside of Boston, Massachusetts, if you're familiar with Boston. I'm sure you know of the sister city to Boston, Cambridge, right across the river, which is where Harvard is, to kind of give you a scope of where Connecticut is, an hour outside of Boston and Harvard. But what I want you to see is in this picture that being in the northeast corner of the state of Connecticut, it's very rural. You see lots of hills and smaller mountains and forests. It's a very rural agricultural area. And in that area of the state, you are dealing with a more rural population with less access, easy access, I should say, to healthcare systems. Also, in the Northeast will extend over to the Long Island Sound, which again, a lot of sea and fishermen type small towns and villages, which also have a very rural aspect of it. My other history, my actually original starting as a nurse practitioner was through Yale University, which is in New Haven, Connecticut, which is more towards the southeast portion of the state, and this is a more urban area. And I have practiced in all settings, and I'll refer to that, from acute care through primary care through long-term care, delivering primary care in the home. So I've been able to witness the similarities and the differences of the health needs of, in particular, older adults, but families in both rural and urban areas. But today's focus is really on nurse practitioners, but I just wanted to take a moment and say, let's look at where nurse practitioner started and what's the umbrella term, or here I used a CAP for advanced practice nurse, because some people refer to themselves as nurse practitioners, some people refer to themselves as advanced practice nursing. So what is advanced practice nursing? Advanced practice nursing is actually an umbrella term for 4 areas. And as you see in this graduate CAP, you see the NP, and also the doctoral of nurse practitioner in one corner of the CAP. In the other, you have your certified registered nurse anesthetist, which you'll see, then the clinical nurse specialist, and the certified nurse midwife. All are unique in their own advanced practice scope of care and the practice that they provide. But again, as I already said, we really will just be focusing here on the NP role. So how do we define nurse practitioner? We should definitely have a basis of a conversation on a common denominator, and that should be, what's the definition of a nurse practitioner? So a nurse practitioner, as we said, it's part of the advanced practice nurse. So it's a registered nurse with an advanced degree. Now it needs to be a master's or doctorally prepared. They have expert knowledge base. They can perform complex decision-making skills. There's clinical competencies to which they're required to master. They have an extended practice, and they're usually their clinical experiences within a specific population, such as you may be certified as a nurse practitioner for pediatrics, or a family nurse practitioner, gerontology nurse practitioner, acute care, primary care. Over the course, and we're going to be talking about the history, a master's degree is the recommended entry level for any nurse practitioner. So again, let's just take a little moment and really kind of investigate that role of the nurse practitioner. What is the scope of their practice? What can a person do with a title of a nurse practitioner? They certainly can diagnose and manage most common health illnesses, as well as we've developed quite an expertise in managing chronic illness. We're authorized to perform very comprehensive physical examinations. We can order diagnostic tests, we can interpret them, we provide counseling and education, and we write prescriptions and give patients what's not here is one of our expertise is really that education and spending time with the patient and really reviewing and collaborating with the patient and their family on a health plan for successful health and aging overall. So this includes case management, depending in the United States, to which I'll talk about more. State by state has their own regulations for scope of practice of being autonomous and independent, and we'll talk a little bit more about that. That's particularly somewhat of what I'll call ad hoc information is that most of my own particular patient loads, and I've told you they've been over a number of healthcare settings, as well as what I've heard from family and friends, is they're always very pleasantly surprised at the in-depth assessments that nurse practitioners give and the time that they give to really explain procedures that they're ordering, those diagnostic testings, what findings are, and developing a plan. So public-wise, it's taken a few decades, but really have been developed into very trustworthy occupation that now patients are starting to seek out to have as their primary provider and NP. So our practice, so each APRN is accountable not only to their patients, but of course their nursing profession and the licensing board who has provided them their license to practice. And as we've already said, direct clinical practice, guidance and coaching, which is a real specialty of nurse practitioners, as well as providing consultation. So where can an NP practice? An NP, I mentioned myself that I've practiced, I think, in every one that is listed here. Hospitals, for health maintenance organizations or HMOs, within the school setting from primary, elementary school through high school, through colleges, you'll see nurse practitioners providing care in those areas. Certainly clinics, whether they're public clinics or private clinics in the outpatient setting, or also clinics that are associated with, that are hospital-based. Primary care offices is a very expanded role for the NP in the United States. Many of an NP are in primary care practices. And then there are a few privately owned practices by nurse practitioners, and we'll talk about why there's a limited amount of NP private practices as we talk about the scope of practice in the future slides. And there's also a lot of public health roles that a nurse practitioner also has within their setting of scope. So we're going to go and start a little bit about this history, which I said I would talk about in the history of the NP. So the NP is a patient-focused application of an expanded range of competencies to improve health outcomes for patients and populations in a specialized clinical area of the larger description of nursing. again, really looking at improving health outcomes. That's a strong mantra and goal of nurse practitioners, is to really improve the health outcomes of that population that you are caring for. I just wanted to take a moment, and we'll be addressing these in the next several slides. There's been a real social influence on the role of the NP in expanding practice, and some of these social influences have been demographic changes, certainly the aging and the expanding aging population, which is global, has shown an incredible increased need for providers, and especially providers with an expertise in caring for the older adults. It became more prominent as the women's movement started developing and expanding in the 60s and 70s, that women wanted health care that was focused on them as women and the specific needs of women. And nurse practitioners, because they predominantly at the time were women, really, for lack of a better word, latched on or held on to that role and said, let's go and see what we can do to really help with women's health care issues. And we have that nurse midwife as part of that social influence. Certainly human rights movement, looking for more equity and equality in healthcare, rural, urban, underserved areas, helped with the expansion and the influence for the NP role. Medically underserved populations I've mentioned, and also physician specialization. So at one time there was actually a plethora of primary physicians, but over the course of time, I would say probably in the 70s, definitely in the 80s, physicians, as they were training, saw it was more lucrative financially to specialize, and also they were able to focus their knowledge base on a particular specialization, such as cardiology, surgery, endocrinology. And with this specialization, there was a decrease in the number of physicians providing primary care, or at one time they were called internists. And this really opened the door for the NP role, because there was not enough primary care physicians willing to do the chronic illness management, the acute but common illnesses that develop. So that really helped this. By physicians specializing and moving away from primary care, it really opened the door for the NP role. So now we're going to start from the very beginning and where nurse practitioners come from. So in the 40s, there was Loretta Ford, and then later on she collaborated with Dr. Henry Silver. So Loretta Ford was working as a public health nurse in rural Colorado, which is one of our western states, out in the western part. It's rural, it's very mountainous, there's very limited, especially in the 40s, limited urban areas, probably only 2 or 3 major urban hubs. So the majority of health was more of a rural base with ranching and agriculture. And she saw firsthand how the shortage of physicians really left children and families without any access to care. And to fill that gap, she really envisioned a solution in where nurses could receive an advanced education in both clinical care and research, so they could meet the needs of these vulnerable populations, in particular family and children in rural areas. And Loretta Ford began working with Dr. Henry Silver out in Colorado, and he was at the University of Colorado Medical Center. And in actually 1965, they co-developed the nurse practitioner model that she developed as this expanded scope of practice within public health nursing, really again focusing on children. And 2 years later, Boston College, again Massachusetts, the Northeast, initiated the first master's program for nurse practitioners. And 1 year later, Bunker Hill, which was part of Massachusetts General, a major provider, a very top tier research and clinical institution to this day in the United States, also initiated a nurse practitioner program. So after the 60s, when there was the first development of nurse practitioner programs, it was focusing on education, mostly, as I said, in pediatrics, providing that care, and needed advanced degrees. But it wasn't consistent of what the advanced education was, what the scope was, and also getting federal support from governments for this role. So the 70s and the 80s were really focusing on the expansion of nurse practitioner, not only the role, but of nurse practitioners, the number of nurse practitioners, as well as legitimizing the practice. Because in the beginning with nurse practitioners, there was a lot of skepticism and resistance, not only from the medical community as do these nurses, as they were referred to, do they really have the knowledge to care for people, not feeling that their education gave a solid enough basis to be diagnosing and treating patients. The public was very unfamiliar with what a nurse practitioner role was. They saw the nurse as someone at the bedside holding someone's care or assisting in a primary care doctor's office. And even within nursing themselves, nurse to nurse, were a little bit hesitant about what this role was. I can tell you, even in the 90s, when I was first nurse practitioner, I also had some resistance from my own nurse colleagues when I started practicing in the office of what my role was, and not really recognizing that role. And it took some education and just watching my practice for some of the registered nurses to really appreciate the role and respect the role of a nurse practitioner. So in expanding the role and the number of nurse practitioners, part of this legitimizing the profession was also to have the professional as well as the economic acknowledgments. And to look at that legitimizing, it was determined that we really need to have certification. So we could say, here is a basis of knowledge everyone has. You need to pass an exam, just like physicians would pass an exam to become an MD. We had developed exams, and 11 professional organizations during this time frame were developed, really looking at their credentials and adhering to federal regulations and reimbursement policies. So specific to the 70s and 90s, I said we want to expand the role and legitimize it. So how did this come about? So the first, I mentioned Loretta Ford was really focusing in the 60s on the pediatric nurse practitioner role. Then in 71, it was really expanded, and there was the first family nurse practitioner program that went from infancy, from newborn, all the way to the end of life. And in 73, where you saw in the 60s in that previous slide, 65 University of Colorado, then Boston College, and then Massachusetts General, that was 3. And then by 73, just 8 years later, there were 65 nurse practitioner programs existed in the United States. And very important was to have a national organization, someone who would be representing nursing, and NAPNAP, or the National Association of Pediatric Nurse Practitioners, was established as an association to promote nurse practitioners, to provide education, looking at certifications, etc. And in 1975, the University of Colorado, who had the first NP program, started providing continuing education to show that nurse practitioners always need to be evolving. We always need to be up to date in the latest in science if we're going to be effective providers of care. Then in 1978, the Association of Faculties and Pediatric Nurse Practitioners really started focusing in on PNP, or Pediatric Nurse Practitioners curriculum, that curriculums were consistent. We were looking for the same competencies through curriculum. And by 1979, there was approximately 15,000 nurse practitioners practicing in the United States. Then in the 80s, you saw the number of nurse practitioners, 75,000, but they still were not really recognized by the federal government. And the federal government, why is it important? There's a host of reasons why it's important to have the federal government recognizing nurse practitioners. One is our scope of practicing to legitimize that we can practice and care for these people, of whatever, when I say these people, I mean the population that you're caring for. And as well as to be able to bill, to independently get billed. Because up until this point, nurse practitioners were either paid from the physician they were practicing with in primary care or through the hospital. There was no direct reimbursement, such as physicians. It's fee by service. You go in, you're given a diagnosis, the physician writes that diagnosis, it's sent in to the insurance company pays the physician a certain amount according to the diagnosis. Well, nurse practitioners were not allowed to do that. Either the physician paid them a salary, an annual salary, or the hospital paid an annual salary, and it was not fee by service. So in the early 1980s, we start to see the formation of the American Association of Nurse Practitioners, which has been fundamental in the expansion and the legitimizing of the role of the NP. So in 1980, there was 200 nurse practitioner programs, or tracks. We talked about the continuing educations. There began to have guidelines for family nurse practitioner curriculum also. It was estimated 22 to 24,000 nurse practitioners in the United States by 1983. And it was really seen in the early part of the 80s. It was important to have an organization that represented the nurse practitioners nationally in the legal or the federal government arena where health policy is developed. And that is how the AANP was started, looking for a way to organize and represent all nurse practitioners in health policy arena. And we'll talk about, there's a phrase that we use here, is to sit at the table. And if you're invited to sit at the table, it means you're recognized for your worth and your input is sought. So nurse practitioners were asking to sit at the table just as their medical colleagues were, to discuss important health issues for all populations and be involved in health policies that impact the patients that they care for, as well as their own practice. And that is essentially what the AANP has been doing for the past couple of decades. So in the later part of the 80s is where we really see how the organizations of nurse practitioners were really helping with health policy, and the federal government, through grants, was issuing up to $100 million on NP education to make sure it was formalized. There was a specific curriculum and competencies. So all nurse practitioners were somewhat, you knew their educational practices were all equal, that when you went to see a nurse practitioner in a particular state, in a particular area of the state, you're still getting the same quality of care of a nurse practitioner in another state. Or if you want to look at it globally, it would be the nurse practitioner in Taiwan is giving the same exact practice and has the same education and knowledge and skill background as someone in the United Kingdom. In 1989, 90% of nurse practitioner programs were either at the master's degree or post-master's degree. So a nurse might have already had a master's of science, but not specific to the practice or the NP practice, and we're coming back for a post-master's degree. And also, which is important, and we'll be talking a little bit more about in communication, the importance of having a journal to advance our science and communicate with one another. And the American Association of Nurse Practitioners Journal did begin in 1989. And very important was the signing in 1989 of the Abundant Reconciliation Act, and that's President George H. Bush in this picture actually signing this act, which provided for reimbursement for the nurse practitioner. So as I said previously, in the United States, up until 1989, nurse practitioners were given a salary either through the physicians that they were privately practicing with or through a hospital. And through this act, it was limited in what they could be reimbursed for, but nurse practitioners could independently be reimbursed for some of the services they provided, but not all. And in the 1990s, this was a continuation of striving for this legitimization through federal funding to advance the role of the nurse practitioners. So again, here there was a master's level of education was required for nurse practitioners. Nurse practitioners, as I'm pretty sure I said, started out in really primary practice and in public health, was now being introduced that to develop curriculum and having nurse practitioners who specialized in acute care settings, such as hospital settings. And the AANP, the American Association of Nurse Practitioners, started to work with other associations and expanding the role, or I should say collaborations outside of the United States and looking more globally, and started with the Royal College of Nursing in the United Kingdom. And importantly, in 1994, there was a publication on the advanced practice nursing that it was as good as the medicine you receive from physicians. This was crucial in many aspects. One, it was published in the New England Journal of Medicine, a premier medical journal, to have an article about nurse practitioners. This was an incredible, I can't express how huge and significant it was to have this article in the New England Journal of Medicine. And then the content showed that especially in primary care, health outcomes, which nurse practitioners, I said in the early slides, the definition of a nurse practitioner is really part of our focus is looking at health outcomes, and that the health outcomes that nurse practitioners provide is as good as, and that's sometimes better in certain areas than medical providers, MDs. This was a phenomenal, foundational publication, and this really showed and gave evidence for the importance that nurse practitioners are not only cost effective, but the quality of their care was exemplar. Very important. And so then in 1997, you see a picture on the right, that's President William Clinton signing the Balanced Budget Act. And in this one, it opened and made more of a broad, direct reimbursement for the nurse practitioners, where in '89 there was limited in reimbursement. This opened up this reimbursement for nurse practitioners exponentially. And in 1999, there was approximately 68,000 NPs in the United States. Which brings us up to the 21st century, and what have we been doing for the last 20 years? Well, we're still battling for legitimacy in certain areas. In the United States, it comes into looking at the prescriptive authority and the full recognition of nurse practitioners in the healthcare through insurance, which is a driver of payment in the United States, as insurance companies have a lot to say on who gets reimbursed, how much they're reimbursed, and for what they're reimbursed for. So insurance companies are very important in the United States. We don't have universal health care here, where everyone has the same access, the same universal, hence the name, care. You pay for your health insurance, and according to what you pay is the level that's reimbursed. So that's kind of in a nutshell. Certainly we can talk more about when I speak to you face to face in a couple of weeks. We can talk more if you'd like about insurance companies to understand the difference, but it's very different in the United States than in most of the world, which has universal health care. So insurance companies and prescriptive authority is very important for nurse practitioners here in the United States. And we're going to talk about what the different levels of prescriptive authority is in just the next slide. And again, looking to legitimize and organizations to represent the acute care nurse practitioners then joined in and became part of the American Association for Nurse Practitioners. So this really is a very large, powerful organization that lobbies for nurse practitioners. In 2004, it was very important. Congress indicated that we would now have, or it's called a proclamation, a National Nurse Practitioner Week. Why this was important is because it's now saying the government is legitimizing, they're saying how important nurse practitioners are, that we're going to celebrate them for a whole week, and it's usually in November. So this really, when we started in 65, in the 70s and 80s, we were trying to become legitimized, not only through the public, but through the government, and it took till 2004 before we became recognized and have a National Nurse Practitioner Week. And by the end of the 2000s, there was approximately 130,000 nurse practitioners in the United States. So this past decade, what has been happening? In 2010, the AANP, that American Association of Nurse Practitioners, attends President Obama's White House briefing on healthcare reform legislation. I had mentioned earlier the phrase to sit at the table, to have a seat at the table. And this is what in 2010 was for nurse practitioners. AANP was asked to come and sit at President Obama's table, so to speak, to discuss healthcare reform. It would not just be physicians and even social workers and certainly policy makers, those whose life has been devoted just to policy. This is inviting nurse practitioners who are providing a large amount of care to a variety of, but mostly underserved populations and vulnerable populations to come to that table and have their voice heard. So this was a real hallmark in our legitimization, is we were asked to sit at this table. And then just this year, with our new president, Joe Biden, in 2021, he asked Rear Admiral Susan Ortega to be the acting Surgeon General. The Surgeon General oversees all of our health policy and is the spokesperson for health policy. If the Surgeon General, smoking is a good example here, the Surgeon General announced, way back in the 60s, before most of you were ever born, that smoking was bad for the health. And there was the stamp of approval from the Surgeon General. So it really emphasized the importance. If the Surgeon General said this was important, it was important. And Joe Biden, our president, had a nurse practitioner actually acting as the acting Surgeon General. Unfortunately, a physician was appointed to be the formal Surgeon General, but we're starting where we had a nurse practitioner as an acting Surgeon General, and hopefully in the very near future will actually hold that position for the entire appointment. So now let's take a look at scope of practice that I've been talking to you about, that in the United States, each state, and you'll see on the right, there's a picture, of the United States with all of the states and their initials is what's inside. So if you start on the right, upper right hand corner, you see ME, that's Maine. And next to Maine is in green, kind of a triangle shaped state, is New Hampshire. And next to New Hampshire, an upside down triangle, is Vermont. Under Vermont and New Hampshire is Massachusetts. That's where Boston is. And under Massachusetts in the green is Connecticut. That's the tiny state. And as if you look at Connecticut compared to especially the states in the western part, it's a small geographic state, but very large in population. The Northeast is very dense in population, and where many of the top tier research and clinical medical and nurse practitioner institutions are, not all, but many. So what this pictures to denote to you the three colors, the green, yellow, and red. And green is the 23 out of the 50 states in the United States that allows a nurse practitioner to have full practice authority. They can prescribe, including controlled substances. They can order hospice and home health care, amongst other things. And they have full practice authority. Which of course is always regulated by your Board of Nursing. And then we have 16 states, and those are the states in yellow, and they have limited practice authority. Often has to do with prescribing as well as reimbursement of what a nurse practitioner can reimburse, whether they can independently reimburse or it needs to be under a collaborative agreement with a physician. And then we have 11 states, and you'll see it's if you knew the United States culture, it's somewhat very political. That the states in red, other than California, way over in the west and the left side, the other states are what we know as Republican states, and that's all called a red state. And it just so happens that most of these red states, not all, have a very reduced practice authority for nurse practitioners. They have to have a collaborative signed agreement with a physician to which they practice, and they practice under his license. And you have actually a very detailed collaborative agreement of what the nurse practitioner can do and can't do under that collaborative practice, and also what medications that they can prescribe and not. And it's usually the controlled substances, such as narcotics, where the nurse practitioner will be very limited. So that gives you an idea of the scope of practice. It's still not a full practice authority in all 50 states, but certainly the organizations are working very hard, that AANP, working very hard through lobbying at the federal government for full practice in all states. And why we want that is so that we really can give the full scope of practice to the patients we care for to really improve those health outcomes, is why we're looking for the full practice authority. And this, I won't go through this slide, but I encourage you to read through this slide. And again, it just really describes a little bit more so you can see it in black and white, the difference between a full, reduced, and a restricted practice authority and what that means for the nurse practitioner. So now I want to take the role of the nurse practitioner that started in the United States with a conceptual thought by Loretta Ford in the 60s, and then worked with Dr. Silver and the development of the first nurse practitioner program way in the 60s, up until where we are in the United States in 2021. And now let's look at where does all that fit in the global, because we are in a global health arena, and that was certainly evident right now with the current pandemic of COVID-19. We see the importance of global health. So I want to just also take some time and really look at what has the international scope of practice be. So one of the things legislation has been looking for on an international scope is to really look to protect that title of a nurse practitioner, an advanced practice nurse. And what we mean by protecting it is that this is the definition, this is the competencies that you must have mastered to become a nurse practitioner, this is the licensing for it, and this is an international, it's not just country by country. That there's regulatory mechanisms that are specific to advanced practice nursing to oversee the scope of nursing practice versus originally it was often medicine who was the regulatory mechanism for advanced practice nursing. And internationally, we're saying no, nurse practitioners can regulate themselves. And certainly to be officially recognized for the titles that nurses do work within their role. So now I'm going to, and you're much more of an expert than I am in Taiwan, but I want to focus now, we took the United States view, we looked at it very briefly at an international scope, and now we're going to bring it down specific to Taiwan. So Taiwan, it was almost 20 years later, and this is very typical in most countries outside of the United States. It wasn't until the 80s that the nurse practitioner role was developed. Again, and this was often, in specific to Taiwan, was a shortage of residents in the hospital setting, where in the United States we didn't have enough primary physicians in the rural areas, which was the impetus for nurse practitioner role, where in Taiwan it was a shortage of residents in the hospital setting. And then in 2014, which is only 7 years ago, there was actually an amendment of the nurse practitioner scope of practice, and what they can do legally under a statute with protection was signed and approved as an amendment. So that is really important to have that more of a federal recognition of the scope of practice and the protection of the NP. And in the 2000s, I don't have a 2021, I'm sorry, I couldn't find the most recent, but there's over 7,000 NPs in Taiwan who are now protected by this particular legislation that was amended in 2014. So how do we communicate? We talked about in the United States we have 50 states. Each state has its own nursing board, so that's 50 different nursing boards looking at the scope of the nurse practitioner role. Then we look at it internationally, and how do we communicate to advance and have, I talked about internationally the importance to have a basis foundation of what the definition is, what the qualification, and what the scope of practice is. So how do we develop that communication to have a more universal role of nurse practitioner internationally? Well, it started with journals. And I mentioned that really hallmark article in the New England Journal of Medicine saying that nurse practitioners' outcomes were as good and in some areas superior to that of physicians. In journals, we communicate through journals, and journals usually have access internationally. And this is the way we share our science, we share good clinical practice guidelines, we give exemplars or case studies to demonstrate, so it's through journals. And also through organizations. So I mentioned earlier that the AANP is a very instrumental organization for NPs in the United States. And they started to collaborate internationally with the Royal College of the United Kingdom. And this was a way organizations started saying, let's reach out to other countries and invite them to come to our conferences. Let us know what their scope of practice is, what their educational processes are, things that are going well, what are their challenges, what are their barriers, how have they overcome barriers, and to share those roles and get to know one another's practice. And we do this through annual conferences. And I'll give you a good example. of the difference in just a short period of time. I am a member of a number of organizations, mostly related to gerontology, because that's my particular population focus. So one of my organizations that I am very involved in the board level and chair level is GAPNA, the Gerontological Advanced Practice Nurse Association. And just 5 years ago, I would say that GAPNA organization was pretty much just limited to those within the United States. Not that we would not allow or encourage people from other countries to be part of this organization, but we really didn't advertise ourselves, and we started to advertise through journals, through organizations. We would take out ads, and we now do in this GAPNA organization have a much more international view, and in fact I've been chair of the research committee within that organization, and we now have members just in this research committee from Australia, the United Kingdom, and Sweden, and we do our meetings for Eastern Standard Time. We will conduct meetings at 8 or 9 p.m. to allow for the different time changes. The United States itself has three different different time changes, and then the international time changes. And also we started communicating as a profession more academically. So through journal writing, you learned of different programs and different researches being done at different parts of the world. And as a researcher, I've done it myself. I've read an article, I found their study really interesting, and I will email that researcher in another country and have a discussion about their work, and this might lead to a collaboration. And through this, also colleges started collaborating together. So an example would be when I was with Yale University, we had a sister school in China that we provided educational materials and would go over and teach or teach online with. At Duke University, we also, which I have taught, we also had a presence in some Asia countries, mostly China. NYU, the New York University, had a presence in China as well as in Italy. And some courses, faculty would go in the summer months and teach courses that we taught in the fall and spring. Here in the States would provide them in countries such as Italy. So you'll see more of academia. At Duke also, I wanted to say, it was Sweden. We had a collaboration with the university in Sweden, to which we would meet and look at and develop curriculum content and look at competencies. So this is the way that we communicate our science, because we legitimize ourselves as a discipline in medicine, because we're still under the big global health of medicine, and health is through our science, that we have our own science. Nurse practitioners develop their own science. That's through research and clinical trials, that we publish that so that people are aware of this knowledge. This is how we develop a science and a discipline, and this is why communication is so important. Other international influences, I've just listed here some different ways to, that have helped expand the role of the nurse practitioner internationally. One is the ICN, the International Council of Nursing, which really looks at the international nurse practitioner, which was developed in 2000 to really facilitate that communication amongst nurse practitioners on a global stage. WHO, the World Health Organization, really emphasize that nurse practitioners are a really powerful instrument to be used to improve and reform our healthcare systems and our policies. They're essential to meeting the needs of, on a global perspective, the nurse practitioner is needed. Project HOPE was started in 1958 as a global health and humanitarian relief organization that relies on volunteers from nurse practitioners. And then, of course, social media. I spoke about conferences and journals, but that's just one area of social media. We're all on Twitter. Back in the day of Facebook, people still use Facebook, but not as much as the younger generation who use Instagram. And I know as a faculty member, I am strongly encouraged to have a social media presence. I'm not as good as I should be, I'll be honest, but to have a social media presence through Instagram and to be tweeting the newest advances that are out there, new discoveries, new areas of collaboration. So social media, because it is such an international venue for media, has really expanded the breadth and depth of the nurse practitioner. So the future, where do we need to go? And we're going to talk about this a little bit more in depth when we actually have our conversation face to face and looking at the educational requirements. Here in the United States, originally, the educational requirement for nurse practitioner became from a certificate to that of having at least a master's entry level, and now we have a DNP, or a doctorate nurse practitioner. It's not mandatory. However, there is the constant discussion on at what date should a master's no longer be the entry level, but it should be at a doctoral level. Looking at that scope of practice, I showed you just in the United States that we have only 23 out of our 50 states that have full scope of practice, so we're constantly looking to advance that. Legitimization, again, that in fact affects our scope of practice, as well as legitimizing ourselves as a true science, a true discipline, as well as economically to being reimbursed independently for the services we provide. What are our collaborations? How can that advance science? How can it advance health outcomes for all populations? And how can it improve global health? I talked about science and financial impact, and we can talk about that a little bit more in depth if you would like when I'm actually meeting with you on the 14th. These are some resources that are available internationally if you would like, and I strongly encourage you to be involved in Sigma Theta Tau International. I did that myself as a master's student. I was inducted into Sigma and found it very helpful. There's the International Council, which I've talked about, and there's also foreign service medical providers that you can read here on a way of also providing care, which includes nurse practitioners. So these are some resources that are available, and these are just some. I provided some of the references that I used for this presentation here. If you would like a more in-depth literature review of some other sources that I've used as kind of background knowledge, I certainly can provide that for you. I thank you very much for listening to this presentation, and I look forward to talking to you on the 14th.